Welcome to the session on blood pressure management in the operating room. I think we all know that hypertension are major problems we deal with, and it affects the outcome of our patients. And so this snap talk was put together to try to give you some additional information and knowledge and techniques as to how to optimize blood pressure management there. I'm Ron Pearl, Professor of Anesthesiology, Perioperative and Pain Medicine at Stanford University, and I've had the privilege of both putting this session together and also being one of the speakers. I'm going to introduce the other three speakers. They are superb now, so that we can, after that, just continuously go. And at the end, each speaker is going to take 10 to 12 minutes or so there'll be plenty of time for questions. Rashmi Sridharan is Associate Professor of Anesthesiology at the Cleveland Clinic Lerner College of Medicine and Case Western Reserve University. She is an anesthesiologist, intensivist, and the interim chair of the Department of Anesthesiology at the Cleveland Clinic. She serves as Vice Chair for Education at the Integrated Hospital Care Institute of the Cleveland Clinic, leading education across multiple departments, including anesthesiology, emergency medicine, pulmonary critical care, and hospital medicine. And she will be discussing continuous invasive and non-invasive blood pressure monitoring options. Dr. Bernd Sogel is Professor of Anesthesiology and Vice Chair of the Department of Anesthesiology in the Center of Anesthesiology and Intensive Care Medicine at the University Medical Center Hamburg-Eppendorf in Germany. He's board certified in anesthesiology, internal medicine, and intensive care medicine. His research focuses on the concept of personalized hemodynamic management for both high-risk surgical patients and critically ill patients. And perfect timing, he's the first author on a large major clinical study related to blood pressure targets, which was published just this week in JAMA. And he will be discussing optimal blood pressure targets. Finally, Patrick Wierzewski is a critical care pharmacist and an assistant professor in anesthesiology and pharmacy at the Mayo Clinic College of Medicine. He's active in cardiothoracic surgery, ICU, and ECMO programs at the Mayo Clinic and is chair for clinical pharmacy research there. His research focuses on understanding human circulatory physiology, hemodynamic dysregulation, and vascular dysfunction, and he will be discussing rational choice of vasopressors. Where is the evidence? So we will go ahead then and start with Dr. Sridharan's presentation.
Good morning, everyone. Thank you, Ron, and thank you all for being here this morning. I do not have any disclosures. Objectives for this segment of the talk would be that at the end of this session, this talk, the learner should be able to list the various invasive and non-invasive modalities that we have to monitor blood pressure in the perioperative period, elaborate on the principles of this monitor, and the technological advances and their implications in perioperative blood pressure monitoring. When we look at perioperative blood pressure monitors, you have monitors that could be direct or indirect. And in the direct monitors, it is continuous. It is our invasive arterial access that we have in the monitoring. Indirect, it could either be intermittent or continuous. Intermittent is the commonest one that we use, is the oscillometric non-invasive blood pressure monitor. Now, continuous, you have three different technologies and devices associated with those technologies which have been used, which is the finger cuff technique, the tonometric, and the pulse wave propagation technique. We'll talk about each of these briefly. So first, going to the oscillometric blood pressure measurement. Of course, the simplest and the commonest form of blood pressure measurement that we use every day in the operating room. The principle behind it is that the oscillations of the arterial wall can be transmitted to a cuff that is filled with air that is surrounding the extremity or the arm, and that could be used to measure the blood pressure. So for example, if we take an arm and you have a blood pressure cuff and it's inflated higher than the systolic, it completely occludes the artery. And once we deflate it over about 40 seconds, blood starts flowing through. That causes oscillations in the arterial wall that is transmitted to the cuff, which results in measurement. The point where there's maximum oscillations of the wall is what corroborates with the mean arterial pressure. Now, it's important to note that the mean is the only measurement that is actually measured. The systolic and the diastolic pressure that we get with the non-invasive blood pressure oscillometric monitoring, they're derived from the oscillometric envelope. The other aspect that is important to note is that this technique assumes that there's a consistent arterial compliance and the pressure of the pulse is consistent throughout. So if there's arrhythmias or if there are situations where the arterial compliance is not adequate, it may affect the accuracy of this monitor and the measurement that we're seeing. So overall, when we look at key considerations with the oscillometric non-invasive blood pressure monitoring, one of the prerequisites, of course, that you need to have pulsatile blood flow for this measurement. Location is important. Generally, arm measurements seem to be more accurate than leg measurements. Now, there is some considerations in patients who are obese because if the structure, the shape of the arm is conical and the cuff doesn't fit well, in that instance, maybe a forearm or a leg measurement might be helpful, but generally, arm seems to be more accurate than other extremity measurements. Now, size is a very important consideration when we're talking about oscillometric non-invasive blood pressure measurements. If it is too small of a cuff, it tends to overestimate the blood pressure. Too large of a cuff tends to underestimate the blood pressure. What is an appropriate size then? It is a size that covers about 40% of the circumference and 80% of the length of the extremity. And that is important to choose appropriately so we can have accurate measurements when we use this technique. Then coming to the important question, how does it compare to an invasive blood pressure monitoring? If you're looking at oscillometric intermittent, how does it compare to invasive continuous monitoring? There was a study that was done looking at a large number of patients when they simultaneously looked at the non-invasive blood pressure and a continuous arterial blood pressure and how it compared. They did notice that when your non-invasive blood pressure, which is measured intermittently, tended to overestimate hypotensive numbers and underestimate hypertensive episodes. This is quite significant in a clinical setting when our goal as a bedside physician is to recognize and treat hypotension in a very timely fashion. And with the intermittent blood pressure monitoring, if the patient is truly hypotensive, there might be an error with that accuracy. So the Perioperative Quality Initiative International Consensus on the statement on the perioperative arterial blood pressure management, they do recommend using continuous invasive blood pressure monitoring for early detection and treatment of blood pressure. I think from a clinical standpoint, what it could mean is that in patients in whom you're either having difficulty in measuring the blood pressure or you're expecting high-risk patients in whom you're expecting some swings in blood pressure in the perioperative period, it might be optimal to consider a continuous invasive blood pressure monitor. Now going on to continuous non-invasive blood pressure measurement, it's trying to kind of take a middle ground between the intermittent non-invasive and the invasive continuous. We have three technologies, as I mentioned earlier, which could be utilized for this continuous non-invasive blood pressure measurement. One, using the finger cuff technology. Two, the tonometric. And three, the pulse wave propagation. The finger cuff one, ClearSight is a good example, the Edwards Life Sciences ClearSight device. It uses a cuff that inflates around the finger and keeps the blood volume constant and constant during the entire cardiac cycle. And the arterial waveform is recreated based on the amount of cuff pressure that is required throughout the cycle to keep that blood volume constant. A couple of things to keep in mind while utilizing this is, of course, if your patient is on a large amount of vasopressors, peripherally vasoconstricted, has shock, it may not be accurate and it may not give you appropriate readings. The other aspect is that this often needs to be recalibrated to a regular cuff measurement to make sure that it's accurate readings. So that's the finger cuff technology. Now the tonometry, it's an applanation tonometer. It needs to be positioned exactly over the artery. Usually it's radial and with a little amount of pressure. It's very similar to us palpating the arterial pulse, kind of feeling the tension of the arterial wall and extrapolating it to a specific blood pressure number. It is kind of similar to that. This transducer is placed with a little bit of pressure on top of the artery, and then using a proprietary algorithm, the arterial waveform is recreated. Now this The biggest concern with this technique is that stability, it kind of needs to be on top of the artery. The T-line device seems to be helpful because it is kind of on a bracelet. The sensor is on a bracelet and it can be placed on top of the radial artery, and this does not require any calibration. Now, the third technique and the last one is the pulse wave propagation technique. It is based on the fact that the arterial pulse, the time that it takes for that pulse to travel from the aortic root to the site that you're measuring, it depends upon the blood pressure and the arterial compliance. Now, it is inversely related to the blood pressure. The longer it takes for this pulse wave to travel from the aortic root to the site of measurement, lower is the blood pressure. Of all the techniques of continuous non-invasive blood pressure measurement that we talked about, this is probably the least developed. It's harder for this to give an accurate measurement of the blood pressure. More can give you the direction in which is the patient going to be hypotensive or going towards a hypertensive site. So these are the three main modalities of non-invasive blood pressure measurement, that continuous non-invasive blood pressure measurement that we have. I just want to touch upon these two randomized controlled trials looking at non-invasive blood pressure monitoring, which is continuous, as compared to intermittent non-invasive monitoring. In both these studies, they did notice that the continuous monitoring reduced the occurrence of hypotension by being able to predict it earlier. In the first study that is mentioned above, it reduced the occurrence of hypotension by a factor of 2, and in the second DETECT randomized control trial, there was a reduction in hypotension by a factor of 10. So yes, it has some limitations, but there is value in being able to recognize, anticipate, and recognize and treat hypotension in a very timely manner. So key consideration with continuous non-invasive blood pressure measurement, finger clamp devices versus the oscillometric tends to identify more episodes of hypotension, helps with the directional change in blood pressure. It's really not meant to be used in scenarios where you're expecting wide swings of blood pressure or non-pulsatility. It might be a valuable tool in elderly patients where you're having challenges with placing an invasive arterial line. And it actually, because you get a pulse waveform, contour analysis can also be done to help assess stroke volume variation and cardiac output and such. Now, going to the gold standard, the continuous invasive arterial blood pressure monitors. It's still the reference standard regardless of the risk involved, the cost involved, and the expertise that is required to establish this form of monitoring. It is superior at detecting hypotension intraoperatively, and again, waveform analysis can be done from contour analysis for volume responsiveness and for cardiac output measurement. I'm going to quickly touch upon the principles. I know all of us are probably quite familiar with it. The measurement of intraarterial blood pressure, it uses a fluid-filled tubing. The force of an arterial pressure is transmitted to the arterial line catheter through the fluid-filled tubing to a transducer. It converts it into voltages, which is amplified, filtered, and then you see a waveform on our monitor. Now you see there are multiple components that are connected in series, and an accurate reading for us to look at and interpret depends upon optimal functioning of all of these components and that we set them up appropriately. So the big things that to think about, there are two aspects of the components involved. One is the natural frequency and the dampening coefficient. Natural frequency is just an effect of the system. The higher the natural frequency, the better it is. How do you have a higher natural frequency? By using a smaller gauge catheter, by using short, stiff tubings, lesser stopcocks. Pretty much use a small gauge catheter and the supplies that comes within your arterial line kit, we should be good. The next piece is the dampening coefficient. Dampening coefficient is the time that it takes for these oscillations to decay once you disturb a system. You want both of these, the natural frequency and the dampening coefficient, to be optimal for you to get an accurate reading. How do we make sure that it's not overdamped or underdamped? What happens if it's overdamped? If it is an overdamped reading, you're probably going to underestimate the systolic blood pressure. If it's underdamped, you're probably going to overestimate the systolic pressure, so you want it to be optimal. The fast flush test that we do at the bedside helps us recognize if it's an optimal dampening that you have. The other things that we could do is to make sure there's no air in the system, there's short enough tubings, and you have less stopcocks, and I think this is a common thing that happens in the OR, is to make sure that the fluid bag that you have is appropriately under pressure so you can consistently flush your line. The other aspect is for us to have accurate measurements and interventions accordingly, it needs to be leveled and zeroed at the appropriate point. It's important to recognize leveling and zeroing are two separate aspects. Zeroing is establishing the reference point to the ambient atmospheric pressure. Leveling is establishing that reference point with respect to the patient's body. Usually, we tend to level and zero at the aortic root, and it tends to work well for supine patients. What we need to be very cognizant about is if the patient is in a position which is not supine. For example, if the patient is in a beach chair position, what you're worried about and concerned about is a pressure in the circle of Willis. So if you are leveling and zeroing at the level of the mid-sternum, you might miss many episodes of significant hypoperfusion at the circle of Willis that would be unrecognized. So important to remember that a 10 centimeter vertical difference in this measurement translates to a 7.5 millimeter blood pressure difference. So depending upon the patient's position in which we're doing the surgery and the arterial pressure, whichever location we are most concerned about, it is important to level and zero at that particular site to have accurate measurements and appropriate intervention. Complications are extremely rare with intraarterial blood pressure monitoring. There was a study that looked at thousands, over 2 decades, thousands of arterial accesses, less than 1% occurrence of complications. From anesthesia-closed claims, only 2% of the claims were associated with vascular access. Of the 2%, only about 8% was from arterial access. So quite a small and rare occurrence of complications. Nevertheless, when they do occur, they could be very significant, like pseudoaneurysms, digital ischemia, and embolization. So to be careful with that. So important consideration for invasive blood pressure monitoring, it is the gold standard. It can also be used when the flow is pulsatile, it's non-pulsatile. We do have to, however, recognize the limitations of the system, make sure the system is optimized, appropriately leveled and zero, so we can interpret the numbers that we're seeing on the monitor appropriately, and make those interventions accordingly for the patient. Now that we looked at the different blood pressure monitoring strategies, one of the things that often comes up, like, what more can I get from these monitors, especially from your invasive arterial line monitors? How else could be optimized and utilize these numbers to improve our patients' outcomes? So one of those things is the hypotension prediction index. It is a proprietary algorithm which was developed by Edwards Lifesciences that it analyzes about 23 components of the arterial waveform, and it predicts the occurrence of a MAP less than 65 millimeters of mercury for over 1 minute within a 15-minute window. And it gives you a score of 0 to 100. Any score that is over 85 indicates there's going to be imminent hypotension. This was a very novel thing that came out, and we felt that it is a game changer because you can actually anticipate the occurrence of hypotension, preemptively treat, and prevent its occurrence. And it also, at that time when it came out, the specificity and the sensitivity of this monitor was quite significant and quite high. As with any novel thing that comes out, many other studies come out, and it kind of probably doesn't pan out to be as cool as it was supposed to be. So there were early demonstrations of significant sensitivity, like very good high accuracy, which was shown. And then the other 2 studies that I've put up here, they were published in 2024. They noted, they looked at the positive predictive value. They looked at having a higher MAP target, which would make you preemptively treat hypotension, versus using a hypotension HPI index of over 85. And they saw that the positive predictive value of the HPI index was only about 29 to 31%. What that means is 7 out of 10 of the alerts that were coming were probably false alerts. The other important piece was that the clinical equivalence between using HPI alerts for a threshold over 85 and a slightly higher MAP trigger, around 70 for preemptive intervention, it's quite similar. So that kind of changed the way we were looking at this hypotension prediction index. I'll close out with this meta-analysis, which was published quite recently. This year, I want to say in the last couple of months. It is a systematic review and a meta-analysis that evaluates the effectiveness of HPI in the prediction and prevention of intraoperative hypotension and compared it to standard blood pressure monitoring techniques. There were 22 studies in total, And the primary outcomes they were looking at was the sensitivity, the specificity, the area under the curve, and the time-weighted average of hypotension. What they found was that HPI had quite a reasonably higher sensitivity and specificity than what last year's study showed. It was showing about 30% last year. And this one, when they pooled all these studies together, it was closer to 50%. But its clinical advantage over a map-based monitoring was really not quite apparent. So HPI had reduced the duration of hypotension, but it is unclear if it really translated to improved cardiovascular and renal outcomes. So of course, we need more independent studies to tease out all those details. I will close out here. Thank you very much. And
we're going to continue now talking about fluid management in the hypotensive patient. Basically, when should we give fluid? We all know that inadequate intravascular volume decreases organ perfusion, results in organ dysfunction, and thus in fluid-responsive patients, giving fluid will indeed be beneficial. But multiple studies show that only about half of patients are fluid responsive. If we give fluid that does not improve things, that excess fluid will cause pulmonary edema. It will also cause other organ edema and dysfunction. And importantly, if that fluid raises central venous pressure but doesn't raise mean arterial pressure, it actually is going to decrease perfusion of vessels. So what we really need are ways to figure out, are we on that steep ascending portion of the Starling curve, or are we on the plateau? Fortunately, there are lots of techniques that have been tried for doing this, and we'll go through all the ones on this slide. First, people think about in terms of static measurements, central venous pressure commonly being used. Unfortunately, it really is not a particularly good predictor of fluid responsiveness. Nice meta-analysis here. Again, about half of the patients were fluid responders, and they found really very poor correlation between CVP and increases in cardiac output index. Area under the curve is really not much better than just a time course. And in fact, in this study, in the operating room, it performed even worse than in other settings. Very popular nowadays has been to use ultrasound to look at the inferior vena cava, looking at two things. One, a static measurement, what is the diameter of it? If there's lots of fluid, you would think the diameter would be large. Not much fluid would contract down. And then looking at collapsibility, which is actually somewhat of a dynamic measurement using the respiratory cycle. We'll talk about those more in a second. So the overall pulsatility. But some problems with this. One, the validations of this are primarily done with spontaneous ventilation and not as reliable in our patients who are likely intubated on positive pressure mechanical ventilation. But secondly, what it really is measuring, correlates well with, is central venous pressure. And as just talked about, central venous pressure is not a great predictor of fluid responsiveness. So CVP, IVC are good in the extremes, but in the majority of patients, not really very good at predicting. A third sort of static measurement that people commonly use is looking at the left ventricle with either POCUS, a transthoracic echo, or transesophageal echo. And this, again, is useful in the extremes when the left ventricle really has no volume in it. Yes, those patients will be fluid responsive. But you'll also see low volumes in the left ventricle during vasodilator states with vasoplegia or sepsis going on. So most of the recommendations nowadays are to try to use dynamic evaluations, usually based upon the respiratory cycle. And again, we'll talk about all of the ones on this slide. And what we're trying to do here is to use respiratory cycle, changing intrathoracic pressure, that then changes the venous return to the heart throughout that respiratory cycle and changes the cardiac stroke volume and blood pressure. We're used to thinking about inspiratory time, spontaneous ventilation, decreased intrathoracic pressure. results in increased venous return to the heart so that there's greater ejection from the heart, and we'll see higher systolic pressure and higher pulse pressure. And with positive pressure mechanical ventilation, actually, it's a much more confusing situation, but the exact reverse ends up occurring. So this is what spontaneous ventilation looks like, and you'll see that during inspiration, blood pressure and pulse pressure are high, and during expiration, the venous return drops off, and those values are low. Similarly, for positive pressure variation, we see the reverse parts. During positive pressure inspiration, we get decreased systolic pressure, decreased pulse pressure. During expiration, it increases. Lots of studies, I like this one because it's pretty compelling, sort of compared central venous pressure to these patients who were given fluid boluses. Some responded and some did not. As you'll see, CVP, essentially identical, no predictive value at all. In contrast, if you look at their first pulse pressure variation, responders 18%, non-responders 4%, really differentiates. Same for systolic pressure variation. A couple of things. These are the sort of numbers I tend to use. Different studies have used different numbers, but they predict when patients will not respond to fluid administration. And what we're most interested in are not whether patients will definitely respond, but which patients should we not be using. But to use this respiratory variation, you need to have positive pressure ventilation with tidal volumes of at least 8 mils per kilo. Patients cannot be spontaneously breathing or initiating breaths beyond pressure support ventilation, etc. They need to have sinus rhythm, normal right heart function, and a closed chest. In addition to looking at blood pressure, with these variations, one can look at stroke volume or cardiac output. One can use some of the continuous blood pressure devices that use pulse contour, the ones that you just heard about in the last talk, and that can give you instantaneous stroke volume to tell you whether you got improvement from the respiratory variation. You can use echocardiography, looking at the left ventricular outflow tract velocity time integral. A meta-analysis of studies, again, comparing these to central venous pressure, lots of studies there. They, on average, different ones used it in terms of prediction, CVP around 9, the pulse pressure and stroke volume around 12%. And you'll see that here, CVP, it, again, has some predictive value, but its sensitivity and specificity were not that high, much better with dynamic measurements. So of a different version of dynamic respiratory cycle look is the end expiratory occlusion test. What this does, instead of regular respiratory inspiration, expiration, it uses a 15-second or longer expiratory pause. And during that time, you can see what happens to blood pressure, or if you can measure against stroke volume or cardiac output, a 5% change indicates fluid responsiveness, and this has very high sensitivity and specificity. One technique which is heavily recommended when possible because it has extremely high predictive value is called passive leg raising. It doesn't mean you go and you pick up the legs. What it is you start off with the patient in semi-recumbent position on a bed, so the torso and head are elevated 45 degrees, and then you just go ahead and basically move the bed into what would be Trendelenburg position so that the torso and head are now horizontal, the legs are up at 45 degrees, and that basically moves about 300 milliliters of blood from the capacitance vessels in the lower part of the body into the circulating blood volume. It is, in one respect, actually a true fluid challenge. It's just an immediately inducible and reversible and can be very useful. In the OR, we're not likely to have patients semi-recombinant like that, but you can talk about actually taking the patient and putting them into a supine position. Last, what do we do when none of these are actually able to be used? And here, normally, in the past, we would go ahead and give a regular fluid bolus, 250 to 500 milliliters, over a 10, 15, even 30-minute period of time. The mini fluid bolus, what you do is you give 100 to 150 mils, so a relatively small amount, over 1 to 2 minutes. That is enough to rapidly expand the blood return to the heart. You look for generally increases in cardiac output, but one can also look at what happens with blood pressure. This is very highly sensitive. The amount of fluid you give is less likely to produce any adverse effects, and it rapidly redistributes. And in fact, if the patient is fluid responsive, you will have quickly done something good for those patients. Last, just emphasize these dynamic measurements that we've been talking about. Multiple studies have demonstrated that goal-directed fluid therapy has marked benefits for the patients, decreased hospital length of stay, decreased complications after abdominal surgery, faster return of bowel function. Oops. So in summary, static measurements such as CVP are not all that effective in predicting fluid responsiveness. Passive leg raising, when you can do it, is simple, effective, and reversible. Dynamic measurements using the respiratory cycle and looking at systolic pressure variation, pulse pressure variation, stroke volume variation are sensitive and specific as long as your patient's in sinus rhythm and your tidal volume is 8 mils per kilo. The mini fluid bolus may be the best approach when none of the above techniques can be applied. And finally, remember Goldilocks, not too much fluid, not too little fluid, just the right amount, and that will improve your patient outcome. Thank you.
Yes, good morning, everyone. What is the optimal blood pressure? A question that I would have answered differently last week. Then I will answer it in a few minutes. Before we start about intraoperative blood pressures, we speak about what is a normal blood pressure in a healthy person, and we can look at cardiology guidelines from Europe or just published in the United States, and you will know that a normal blood pressure is defined as a blood pressure of 120 over 80, which translates to a mean arterial pressure of 93. I guess you also agree that during surgery, mean arterial pressure often is lower than 93, and during the last decade we saw numerous, more than 30 retrospective cohort studies looking at the association between intraoperative hypotension and postoperative organ injury. And what those observational studies clearly show is that low blood pressure during surgery is associated with postoperative organ injury, specifically acute myocardial injury and acute kidney injury. And therefore, we recently made the consensus statement for the Perioperative Quality Initiative that intraoperative blood pressures with a mean arterial pressure lower than 60 to 70 are associated with acute kidney injury, myocardial infarction, and death. And the injury is a function of hypotension severity and duration. So from these observational studies, we can say that we probably should avoid profound and prolonged intraoperative hypotension. But the reasonable question then, of course, is should we try to keep blood pressure at higher levels to thereby avoid hypotension? And to answer this, we cannot look at retrospective cohort studies, but we need to look at randomized trials on targeted blood pressure management. In the next couple of minutes, I will show you 5 trials, and 3 of those trials were just published recently, 2 of them only 3 days ago. So the first trial we look at is published in 2021. It's a single-center randomized trial from Switzerland. Included patients older than 45 who had major non-cardiac surgery and had a high baseline cardiovascular risk. 458 patients were randomized to a routine target MAP of 60 millimeters of mercury or higher, or to, and this was the intervention, a target mean arterial pressure of 75 or higher. What we will always do when we now look at those randomized trials is we would need to make sure that the intervention actually worked, so that targeted blood pressure management actually resulted in intraoperative blood pressures that are different in the intervention and in the control group, so that there is a difference in hypotension exposure. Everybody quantifies intraoperative pressures a little bit differently. In this trial, it was defined as or quantified as cumulative time below certain thresholds. And you can see that the cumulative time between below a mean arterial pressure of 75, 65, and 60 was shorter in patients assigned to the higher blood pressure target. So there was a difference in blood pressure exposure between the groups. Primary outcome was a composite, and then most of the trials I will show you, so in this case it was acute myocardial injury within the first 3 days, and or 30-day acute kidney injury or major adverse cardiovascular events. And this primary outcome occurred in 52% of the patients in the 60 target group and in 48% of the patients in the 75 target group. So this difference was not clinically important and it was not statistically significant. Next up, we can look at a large trial. It's a POISE-3 trial, 110 centers in 22 countries. Also high-risk patients, older than 45, inpatient non-cardiac surgery, high cardiovascular baseline risk. And in this trial, all of the patients had at least, or were on antihypertensive therapy with at least one drug. Very large trial, 7,490 patients randomized to a complicated blood pressure management strategy. One was a hypertension avoidance strategy that included an intraoperative mean arterial pressure target of 60 or higher, or a hypotension avoidance strategy that included an intraoperative mean arterial pressure target of 80 or higher. Their intraoperative data are not very high granular, but if you look at the supplementary appendix, you will at least see that hypotension was very rare in both groups. So blood pressures below 60 were rare in both groups. But the percentage of time with a mean arterial pressure higher than 80 was higher in the hypotension avoidance group. So I would also say that that there was a difference between the groups in hypotension or blood pressure exposure. Composite here was major cardiovascular complications within 30 days after randomization, and this occurred in 14% of the patients in the hypertension avoidance group with a 60 target, and in 14% of the hypotension avoidance group with a target of higher than 80. Then a trial that was published, I think 2 or 3 weeks ago in the Journal of the American College of Cardiology, a 3-center trial from China. Very similar patient population, older than 45, major abdominal surgery, high baseline risk. 1,500 patients randomized to a interventional mean arterial pressure target of 80 or higher, versus a relatively complicated definition in the control group. So the target map was the higher of 65 or 60% of baseline, which if you assume that a normal mean arterial pressure is 93, or let's round it up to 100 and 60%, so it's around about 60, so it's not a lot of difference between the two definitions, and only 6% of the patients in the trial actually had not the 65 target, but were the 60% of baseline target was the one that was applicable. So just remember, it's basically a 65 target in the routine care group. Again, where the pressures different, we can look at intraoperative median values here in this box plot. So it's a box plot every 30 minutes during surgery. And you see that the intervention group, the higher target group, had higher blood pressures. A better quantification may perhaps be even this reflected histogram showing the average of the 10 lowest mean arterial pressure values. And here you can see that there is a difference between the groups. Composite outcome again, myocardial injury or infarction, new onset clinically important arrhythmias, acute heart failure, stroke, cardiac arrest, or death within the first month after surgery. And this occurred in 13.6% in the 65 target group and in 14.5% in the 80 target group. So again, there was no difference. Then 2 more to go. The first one published this week in JAMA. It's a pre-treat trial, 2 centers from the Netherlands. It's a relative low-risk patient population, so patients needed to be older than 18, had elective non-cardiac surgery and only required to be in the hospital for 1 night. A trial that was stopped early for futility, I can tell you that already, included 3,500 patients, and those were randomized to routine blood pressure management with the 65 target or to a risk-based blood pressure strategy, which basically meant that there was an algorithm to determine before surgery how high the risk of a patient will be to develop intraoperative hypotension, and then according to the risk group, the mean arterial pressure target was either 90, 80, or 70. So a little bit complicated, but a kind of risk-based definition of the target. Pressures were different. If you look at any MAP, less than 65, area under mean arterial pressure of 65, or the median average mean arterial pressure. So again, the intervention group had substantially higher blood pressures. And now I surprise you, it was a different primary outcome. It was not a composite of organ injury. This time it was postoperative disability within the 6 months after surgery. And this was quantified by the HUDAS scores, a score ranging from 0 to 100. And higher scores indicate greater disability. This score was 18 plus minus 20 in the routine care group, and it was 17 plus minus 20 in the risk stratified blood pressure target group. So again, there was no difference. Finally, our trial that we published 3 days ago, it was on individualized blood pressure targets, a 15-center trial in Germany. We included patients who were older than 45, had elective major abdominal surgery that was expected to last at least 90 minutes, and those patients needed to have an additional high-risk criterion. We randomized 1,142 patients to routine blood pressure management with a 65 target or individualized blood pressure management, and this was, we asked clinicians to keep intraoperative mean arterial pressure above the preoperative mean nighttime mean arterial pressure from the induction of general anesthesia until 2 hours after surgery. So we measured blood pressure using an automated device for 1 night every 30 minutes, and we calculated the preoperative mean nighttime pressure between midnight and 6 a.m. according to cardiology guidelines. Nighttime blood pressures, median was 84. Most of the patients were between 75 and 95, so these mean nighttime ups were substantially higher than the 65 target in the routine care group, and consequently intraoperative blood pressures were higher. In the intervention group, again, box plots, in my opinion, don't show the difference very nicely, but we also looked at areas under blood pressure thresholds, and this makes clear that hypotension exposure differed between the groups. We looked at acute kidney injury, acute myocardial injury, non-fatal cardiac arrest or death within the first week after surgery, and this occurred in 30.5% in the routine care group and in 33.5% in the individualized group. Narrow 95% confidence intervals of the relative risk and no difference. And this robustly neutral result was also confirmed in all per protocol and sensitivity analysis, so also in all of the patients that we analyzed according to pre-specified degrees of preoperative arterial hypertension, so not a signal that any subgroup of hypertensive patients benefits. So balancing the evidence from observational studies and randomized trials, I would still say that we should avoid profound and prolonged intraoperative hypotension, which I personally would define as a mean arterial pressure less than 60 for a couple of minutes. We should not generally keep blood pressure at higher levels, and therefore our recommendation still is valid. We recommend keeping intraoperative mean arterial pressure above 60 in at-risk patients. Thank you very much for your attention.
Great, thank you all. I'm going to wrap this session up and continue the conversation about tailored management. My disclosures are here. Unfortunately, I never see this money. So to start, I'd like to take a little step back, and we consider that normal blood pressure regulatory mechanisms maintain 3 major systems. This is obviously oversimplified, but in brief, we have the sympathetic nervous system with catecholamines, the vasopressin pituitary axis, and the renin-angiotensin system. All of these act in concert to maintain normal blood pressure homeostasis. And the real question is, well, how do we choose between these in what we're going to target when someone presents with hypotension? The SQUEEZE study, published very recently, was a large international observational study of non-cardiac surgery, tens of thousands of patients. And while they found that norepinephrine was the most commonly used vasopressor, what they found was that there was substantial heterogeneity between the centers, and this could not be explained by the case mix or procedural characteristics. And really, interestingly, the authors found that objective measures such as cardiac output, echocardiography, and other things that were discussed earlier in the session were actually used basically never. And this is not very encouraging. A systematic review of 24 studies of non-cardiac, non-obstetric surgery found that norepinephrine followed by phenylephrine were the most commonly used vasopressors for perioperative hypotension. But importantly, they found that the evidence supporting the use of certain vasopressors was very low, and they emphasized the need to tailor treatment to specific patient needs. A very large systematic review of 124 studies of non-cardiac surgery that spanned over 10 surgical specialties, identified 18 different vasoactive drugs that were used. And amongst these, phenylephrine, ephedrine, and norepinephrine were the most commonly used agents. But they found that there was huge variation in practice, and the certainty of evidence of supporting any specific type of vasopressor was very low. And so what this might look like, it may produce an environment that looks something like this, where local practices might adopt a specific first choice vasopressor. They then apply that pressor to a heterogeneous population of patients undergoing surgery. Many of these patients may actually have an optimal effect and probably will have an optimal effect. Some of them may not have any effect or minimal effect, and others may experience adverse events. We then go for a second pressor because the first one didn't work in those select patients, and we have the same story. Some respond, some don't, and so on and so forth. The problem this poses is, as you heard in the previous talk, as you continue to chase your targets and you have vasopressors that fail, you have persistent exposure to hypotension, subsatisfactory perfusion. When you get doses that are high enough, you have adverse effects, reduced responsiveness to vasopressors, and obviously progressive organ failure. The textbooks have long told us what to expect from vasopressors. Many of you have seen studies like this. In vitro, when you take human radial artery and you expose them to different vasopressors at escalating doses, you have an increased contractile response with increasing doses. The same is true with clinical effect in small animals. This is a study of conscious rats without shock. And when you give various vasopressors in escalating doses, there's a dose-response increase in mean arterial pressure. The same is also true in animals when you induce shock. So this is a nice study of dogs that were infused with E. coli. And although the response to norepinephrine after shock is induced is dampened, there was still a dose-response relationship with increased mean arterial pressure with increasing doses of norepinephrine. The problem is these effects don't readily translate to humans that present with hypotension and shock. This is a study of about 3,000 patients with shock that were receiving norepinephrine. You can see at very low doses of norepinephrine, there's a nice incremental increase in mean arterial pressure. But when these doses get excessively high, the incremental increase in mean arterial pressure begins to decline and they become less effective. And so it might be a tipping point at which you're providing more adverse effects than actual benefit. And this is important because excessive catecholamines may be detrimental to cardiac performance. It's a study of patients with sepsis that received norepinephrine, and 1/3 of them developed a new onset arrhythmia. But very importantly here in multivariable analysis, as the duration of norepinephrine and the dosage of norepinephrine increased, there was an increased odds of developing a new arrhythmia. Additionally, in patients that don't have coronary disease, when you increase the norepinephrine dose, their myocardial blood flow declines. This was a small study that demonstrated this, and importantly, these effects were not dependent on changes in mean arterial pressure. A very nice recent study from my wonderful co-presenter, Dr. Selgo. Can see here in tens of thousands of patients undergoing non-cardiac surgery. They looked at the dose-response relationship of cumulative norepinephrine exposure in the operating room and found that as the dosage increased of norepinephrine, the odds of acute kidney injury also increased. And importantly, this effect maintained true after adjustment for relevant confounders, and most importantly, was adjusted for exposure to, or time of exposure to hypotension. Despite this, we continue to use excessive amounts of vasopressors. This is a nice study of over 30,000 patients from the MPOG database that looked at a 5-year time span of patients undergoing major abdominal surgery. They found that over the course of the years, there was less reliance on intraoperative fluid administration and more vasopressors are being given, and they're being given at higher dosages. And while they found that the duration of hypotension over this time period declined, the risk of developing acute kidney injury increased as the vasopressor doses increased. Another issue to discuss is that of catecholamine tolerance. We all know that ephedrine provides a very nice, rapid increase in systolic blood pressure. The problem is these effects dissipate with repeat dosing. The FDA even has explicitly in the label says that tachyphylaxis can occur with ephedrine, and clinicians should be ready to use alternative vasopressors. And so the question is, well, which catecholamine is better? These are results from the VEGA-1 study out of UCSF, nearly 4,000 patients. This was a cluster randomized feasibility trial that compared phenylephrine to norepinephrine. And the trial was positive in demonstrating feasibility. You can see the distribution of the vasopressor doses. But they found no differences in acute kidney injury or other secondary adverse outcomes, and these are being currently studied in a subsequent trial. Outside of catecholamines, of course, vasopressin is released from the posterior pituitary in states of hypotension, and in shock, these release rapidly, but then rapidly also decline. And in patients undergoing cardiac surgery, a study shown here, you can see in patients who are preoperatively exposed to ACE inhibitors and angiotensin receptor blockers, they also demonstrate this increase in vasopressin with hypotension, but then those levels rapidly decline, and they're much larger dampened effect than those who are not exposed to these agents. Vasopressin may also be attractive in patients who have propensity for developing arrhythmias. This is a systematic review of 23 randomized trials that included vasopressin and vasopressin analogs, and you can see that the use of vasopressin with catecholamines significantly reduced the risk of new onset atrial fibrillation compared to when catecholamines were used alone. This was true in low risk of bias studies and those undergoing cardiac surgery. Another very attractive aspect of vasopressin is its lack of effect on the pulmonary vasculature. Of course, there's an abundance of adrenoreceptors in the pulmonary vascular smooth muscle. And you can see when human radial artery, I presented this study earlier, all vasopressors provide an increased contractile response. But when you expose human pulmonary artery segments to various vasopressors, vasopressin elicits no contractile response. In patients undergoing cardiac surgery, when you give them vasopressin, you can see here that their systemic vascular resistance rapidly increases after just 1 hour, and this occurs without any changes in the pulmonary vascular resistance. And importantly, the pulmonary to systolic pressure ratio declines after 1 hour of vasopressin. Disturbance in the renin-angiotensin system is also relevant in hypotension and shock. The angiotensin converting enzyme is an enzyme that primarily lives in the pulmonary capillary endothelium. And when this is damaged from endothelial damage, such as inflammation, sepsis, trauma, the ACE cannot do its duties, and so it cannot convert angiotensin 1 to 2. This is problematic because you don't have the downstream blood pressure regulatory effects of angiotensin 2, which then tells the kidneys to produce more renin. But now there's an excess amount of substrate that can't be metabolized by ACE, and so metabolism is shunted to alternative pathways to produce angiotensin 1, 9, and 7. And these act on receptors like the MAS receptor and angiotensin type 2 receptor and are profoundly vasodilatory. Of course, ACE is responsible for the breakdown of bradykinin, so in its absence, you have accumulation of bradykinin, which also contributes to vasodilation. This then feeds the kidneys to produce more renin, and you have this vicious cycle of vasodilation. One example of this is in cardiac surgery. You can see on the left here, 2 observational studies found that after exposure to cardiopulmonary bypass, renin concentrations significantly increase. In an observational study of 200 patients undergoing cardiac surgery, those who had high renin concentrations after cardiopulmonary bypass were more likely to develop acute kidney injury, and there was a dose-response relationship with more severe acute kidney injury with higher renin concentrations. And this is important because angiotensin II as a vasopressor provides a mechanism for reducing renin concentrations. This is an observational study in patients undergoing cardiac surgery. You can see that those who received angiotensin II had a significant reduction in their 12-hour post-surgery renin concentration compared to standard of care with norepinephrine. In a randomized trial that compared angiotensin II to norepinephrine as a first-line vasopressor for perioperative hypotension and cardiac surgery, I found that those with the highest baseline renin concentrations required the highest amounts of vasopressor postoperatively if they were randomized to norepinephrine, and this effect was not true in those randomized to angiotensin II. Recently, out of the Baylor Cardiac Surgery Program, they looked at patients with vasoplegic shock during cardiac surgery and compared those who received angiotensin postoperatively to intraoperative and found that use of angiotensin II in the operating room was associated with significantly less major adverse events, and this was the Society of Thoracic Surgeons, major morbidities, renal failure, stroke, reoperation, prolonged ventilation, and deep sternal wound infection. And so taken all together, one vasopressor may not fit all, and patient characteristics often consider baseline risk factors in certain predisposing conditions. Of course, you have different physiological targets and the methods that you use to assess those targets. Patients present with different hemodynamic profiles, and they may need different interventions that should be tailored to their specific situation. Of course, biological endotypes also play a role in responsiveness. Additionally, drug characteristics also vary. Vasoactives have a varying spectrum of vasoconstrictive, inotropic, and vasodilatory effects, and they are certainly not interchangeable. And so while we talked about this conventional approach at the beginning where we arbitrarily choose a first-choice vasoactive, perhaps a future state of vasopressor selection takes on a more tailored approach where we provide some sort of profiling and stratifying, where we select patients based off of meaningful characteristics to optimize the effects. And finally, I'll close out by sharing that there's some ongoing studies in this arena that are going to be very important to this topic. The VEGA-2 trial, continuation of the feasibility trial. I recently shared Porthos out of Australia and a very nice study about using angiotensin on induction general anesthesia, just finished out of Wake Forest. Thank you.
We have a couple of minutes for questions, and understand people may need to leave to go elsewhere, so understood if that's the case. First, we have a microphone here if anyone from the audience has questions. Yeah, go ahead, please.
So the map of 65, we had a whole bunch of trials. Who was excluded out of those trials that we shouldn't consider those to be a map of 65? Say somebody was around 200 systolic and they're coming in for emergency surgery. Should we say that's not applicable because those patients were included?
Yeah, in most of those trials, patients with chronic arterial hypertension were included. So, especially in our trial, we not only had the history of the patient, but we performed these preoperative automated measurements. So we really knew if patients were hypertensive, if they were insufficiently treated and hypertensive. And I can tell you, I spent weeks looking at all the subgroups of patients who were hypertensive before surgery because I honestly wanted to find that we need to individualize pressure, especially in those who are hypertensive. And there was no signal whatsoever. So with the hypertensive patients, I would still say that for those, probably the harm threshold is also around 65. We need to address that some of the individual patients, of course, with carotid stenosis or patients with, let's say, very, very substantial high intra-abdominal pressure may have higher pressures or may need higher pressures in individual or specific clinical situations. But I think with all the trials I showed you, the concept of generally or in patients with with chronic arterial hypertension, in those patients targeting the higher pressure is not the way to go.
Hi, Chris from University of Florida. When you're looking at stroke volume variance, does the degree of laparoscopy or the position of the patient during the case make any influence on percentages you're evaluating?
As long as you level your pressure transducer correctly, as we heard in the first talk, or consider when you use an oscillometric measurement that there is a difference in height between the upper arm and the head, I wouldn't say that we need to adapt the target. You need to measure blood pressure correctly in those situations, of course.
I'm sorry, I was thinking more about fluid responsiveness.
Volume variation.
The criteria would be basically the same criteria. Yeah, it is sometimes hard to actually get adequate tidal volumes in Trendelenburg laparoscopy.
Yeah, I'm thinking.
Positions.
I'm sorry, go ahead.
Yeah, go ahead, please.
I'm thinking I do hepatectomies quite frequently. We'll do them robotically, we'll do them laparoscopically, and we'll put them on their feet, and we're just battling where are we at with fluids, where are we at with vasopressors, and how reliable are our numbers.
It is a challenging situation. We all struggle with it. When you're in deep Trendelenburg, you're likely to have lots of volume. Because of that, in addition, we have all the problems in terms of edema that develops from there. So I think most people are going to try to minimize the amount of fluid that people get, unless there's lots of blood loss going on. It looks like a lot on the screen, but it's usually very little.
John Drummond from San Diego. Thank you all for informative talks. Dr. Salgo gets the first question here. Is the information about your exploration of the hypertensive subgroups, is it in the paper or the various appendices? And I ask the question because over time, anesthesiologists have been bedeviled, particularly in medical legal contexts, for failing to live within some percentage of a baseline pressure. And I think you just told me that living within X percent of somebody's extreme hypertension really didn't look very necessary in your study. So the question is that there in a citable format?
The results are in the main manuscript, and all the numeric results are in the online appendix.
Thank you. Valuable stuff.
Yeah. Dr. Drummond, do you want to comment on cerebral autoregulation thresholds? Being an expert in that area, and what blood pressure we need to maintain?
No, not really. I just had a moment of anxiety thinking that all these studies that mean that hypotension, which can be broadly interpreted as the kind of hypotension pressures around 60, it's more like 65 most of the time. These studies are going to give some people a false sense of security and tempt people to be saying, 60 is good enough for all comers. And there are people with vascular abnormalities within the cranium or recent injuries who just are not going to do well neurologically with these kind of pressures. And I just hope our community doesn't get a false sense of security, particularly in the context of neurologic injury or risk.
I couldn't agree more. None of those trials tells us that blood pressure is not important or that hypotension is not harmful. It's just a question of the harm threshold.
Yeah, I just wanted to get your opinion about one of the things I see when we talk about these dynamic variables, and we talk about 8 cc's per kilo. Really, I think what's more important is what is the absolute intrathoracic pressure changes. And, I have young, healthy people with very compliant chest walls that I give them 10 cc's per kilo, and their intrathoracic pressure only varies by 10 centimeters of water. And I have older folks or morbidly obese people, I give them 6 cc's per kilo, and their intrathoracic pressure varies by 30 centimeters of water. And I feel like that is more important in driving the pulse pressure variation, because if you have 30 centimeters, everybody's going to be positive. If you have 10, nobody's positive.
Yeah, correct. It is a continuum. The the higher the tidal volume, the more you will see dynamic variability. Unfortunately, we don't have simple ways we're interested not in the airway pressure, but we're interested in the intrathoracic pressure, and that varies with a lot of other variables. Yes.
Morning, I'm Chawian from Malaysia. I want to ask maybe of all 3 and 4 of you, if a surgeon asked you to lower down the blood pressure, whether it's vascular, cerebral, brain, or spine surgery, first question is, how low can you go? And if you go lower than 65, how long can you go? And the third question is, should you be using the systolic blood pressure or the MAP?
I make it very short. You should use the mean arterial pressure. You should not allow your surgeons to request permissive hypotension. And the statement that you should keep mean arterial pressure above 60, I think is a reasonable statement and is now really, really backed up by good evidence. In my institution, we don't do permissive hypotension. We just taught our clinicians, our surgeons that we don't do it and that it's bleeding because there is a hole in the vessel and not the blood pressure is too high.
I have a follow-up question about that, and that we do have patients who have really, really wide pulse pressure. Usually they've got a lot of atherosclerosis, and we see, a systolic of 140 and a diastolic of 30, and the MAP is 50. What do you do in those cases? I mean, do we go by MAP? Do we not care about anything else, or do we care about systolic mainly? It's often very hard to get MAPs up to a 60, 65 range.
I want to say in those situations, I do tend to go with the systolic blood pressure just because if I know that they're profoundly vasodilated and the amount of vasopressors that you would need to push it to a certain target MAP is also going to be detrimental. So in those situations, I tend to go with the systolic blood pressure. And the other piece about the surgeon requesting for a period of permissive hypotension, we've had that, especially with aneurysm surgeries. We tend to minimize that to maybe like a minute or 2 when we kind of use nitroglycerin to come down on the blood pressure if they just need a minute to get or clip the aneurysm. It's actually the shortest time possible, but certainly not more than 2 to 3 minutes. That's at least in our practice.
What about in trauma surgery and resuscitation? The guideline says that, especially if you've got someone with traumatic head injury, it should get higher, but other patient, you're going at about 60. Does that still be okay?
Absolutely. I mean,
until hemorrhage control.
All the trials that we showed are elective non-cardiac surgery patients. So this is, therefore we only can make statements about this. I agree that in trauma surgery there may be a place.
But for trauma, it's really not the blunt trauma, it's the penetrating trauma that the blood pressure makes a huge difference. And I don't think many people argue that a better blood pressure would, in one sense, perfusion-wise be bad. The problem is that it just produces more bleeding and you actually haven't accomplished anything. We've talked about treating, how low the blood pressure can be. Do we have any real data on how high it is before we have to start lowering it?
At least from observational research and my own clinical practice, I don't consider interruptive hypertension a big problem, to be honest. So all this, we have 2 observational studies showing that there is basically no association between interruptive hypertension and organ injury up to pressures of systolic values of 180 or even higher. And honestly, in major abdominal surgery, or in major surgery, I rarely face a problem that I worry about the high blood pressure, but this may be specific to our practice, I don't know. Do you often have interruptive hypertension?
Yes, we do. Most of the times, I think the anesthesia per se kind of brings it down. But I would say similarly, if they were previously, preoperatively, if their blood pressures were at a baseline of 180, we do tolerate about 160 to 180. I wouldn't treat it if it's not beyond like 200.
Last 2 questions, I think.
Can I ask the panels, what is your threshold for deferring surgery in somebody who has poorly controlled hypertension for elective surgery? And what measurement would you take?
That is a great question. I want to say it all depends on symptoms. If they were chronically poorly controlled hypertension and it is somewhat of an urgent surgery, maybe it's like a cancer surgery that they need, we do talk about the risks involved. As long as they're not symptomatic, as long as it's not a hypertensive urgency or an emergency, we do tend to go forward with it. And that might be our practice, but that's kind of how we have gone forward with these kinds of patients.
Yeah, I think when I trained, yes, we would cancel surgery for significant hypertension. I think we've just gotten so good now at hemodynamic management that that does not apply, at least at the levels we talked about before. We can usually, if we want to get the blood pressure down relatively quickly before surgery, the patients are more unstable, but the large majority of those patients, if they're undergoing relatively uncomplicated surgery, we will be able to do that with safety. I mean, there's a judgment decision, but we've clearly, I think nowadays, are much more liberal in tolerating the poorly controlled hypertension.
Okay.
Maybe a very simple question. So we see all these data suggesting that driving the pressure to a certain degree might or might not help, actually. And there is a trend toward not looking at blood pressure in the postoperative period. So I'm wondering, is blood pressure actually the right variable we are looking for? Or do we need a different variable? And what kind of variable would this be, in your opinion?
Well, but it's an important point that you make. Hypotension is not a disease. Hypotension is a symptom that there is something wrong in the cardiovascular system, and it's a surrogate variable for a much broader picture of complex cardiovascular dynamics. And I think we should look more at cardiac output because it's a main determinant of oxygen delivery. We will next week finish a 1,300 patient trial looking at cardiac output guided management. I won't promise anything because I promised too much with the blood pressure, but let's see.
And I would say, no, it's as we're accepting different blood pressure ranges and intervening as to how you lower blood pressure. We don't yet know the data. Hopefully we'll find that out, but do it the way they did in those studies. You want to maintain perfusion. Very, very different if we lower blood pressure with a beta blocker versus a vasodilator or something which has inotropic vasodilator support, etc.
I'm wondering whether we need something like a more preoperative assessment of organ perfusion, like organ-specific perfusion, brain, kidney, liver, something like this. Or do we have any variables which allow us to assess, oh, there is a ischemic or an area which is probably ischemic or would benefit from a higher or lower blood pressure?
Yeah, well, I don't think we know. I mean, it's interesting, some of these studies dealt with development of acute kidney injury. We know in acute kidney injury, it's actually the blood pressure which governs the perfusion that's going on, as opposed to normally it's the cardiac output. So it's a complicated area. We'll find out hopefully in the future. A last question for Patrick. So if you needed to now choose a vasopressor, what would be your personal choice for the hypotensive patient? And you can talk about intraoperatively cardiac surgery, postoperatively cardiac surgery, and we can get opinions on non-cardiac surgery.
Yeah, I mean, I think it's a pretty loaded question, similar to the arterial pressure question, because it definitely depends on the situation. I would say in most patients, norepinephrine is the obvious choice. Most patients respond, but I think specifically in cardiac surgery, there's a really compelling story for vasopressin specifically with good trial data. The VANCS trial, of course, out of Brazil, now over 5 years ago, demonstrated that it can be used as a first choice stressor in cardiac surgery and reduce AFib, which is really meaningful to those patients.
Yeah. In the OR, what do people choose as your first line? Roshni?
We tend to use phenylephrine as our first choice as far as, the simple cases. If they are non-cardiac patients, we tend to use phenylephrine. And if we're escalating doses, we tend to go with norepinephrine. And in the cardiac operating rooms, I want to say there are multiple choices depending upon surgeons' choices as well. But in general, I want to say it is norepinephrine and vasopressin.
In Germany, we, for the last 20 years, primarily give norepinephrine, and we are very, very surprised that this is now a new research question, whether we can use norepinephrine in the operating room.
And we pretty much have replaced phenylephrine intraoperatively with norepinephrine now. I think part of the reason everyone liked norepinephrine is it was easy to give. Nowadays, where we have norepinephrine coming in pre-filled syringes at a concentration or in bags which are diluted, as I said, our residents have voted for norepinephrine when we work them. I want to thank our speakers, but also thank you all. Great audience on the last day of the ASA. I hope you've enjoyed the meeting and hope this is useful for you in your practice. Thank you.